I'm proud of the NHS because despite all the challenges, people are always focusing on trying to do a better job.
I'm proud of the NHS because it matters.
I'm proud of the NHS because every day we help ordinary people get their lives back and live healthily in their communities doing what they want to do.
I'm proud of the NHS because every day across the country, millions of people get really good care.
I'm proud of the NHS because it is totally committed to the benefit of its patients.
I'm proud of the NHS because they're so resilient.
I'm proud of the NHS because it does a really good job for not actually a lot of money when you compare it to our spending, GDP spending compared to other countries.
I am proud of the NHS because two reasons. It is unique in the world as delivering free healthcare at the point of use to everyone, irrespective of who they are. And secondly, because my wife is a nurse and has worked in the NHS her entire life, I'm very proud of her.
I'm proud of the NHS because we single-mindedly deliver for our patients.
Absolutely vital.
Emotive.
Incredibly innovative, incredibly resilient, and incredibly strong.
Complex at a level that people don't necessarily appreciate, which I know isn't one word.
Committed, quality.
And rewarding, I think was the third one.
Committed, quality and compassion.
I would describe the NHS in 3 words as essential, resilient and caring.
NHS in 3 words, it does everything.
I'll describe the NHS in 3 words. Absolutely bloody marvellous.
Ladies and gentlemen, please welcome Conference Chair Anita Anand.
Now this is weird. We've suddenly gone a bit cabaret. I feel like we need sort of some kind of candlelight and crooning in the front. Welcome to you all. We're on the final straight now, the last day of what has been an absolutely fascinating conference. And I hadn't seen that video until just now, just with all of you, and I found it a little bit moving. And I just wanted to say thank you, because you've been telling me here and us while you're proud of being with the NHS. I wanted to say thank you to the NHS because you gave me my 2 beautiful little boys and you helped my mum when she had a stroke. So I am profoundly grateful to those people who work for the NHS in the very best of times and the very worst of times. So we've had a lot of information packed into these 2 days, dense with information, and I thought yesterday was really very important, particularly those slides that we saw from Anita Charlesworth. There's been a lot of talk about the fiscal challenge that lies ahead of all of you, but to see it starkly in those graphs and pictures, I thought really brought it home. And we had speakers from around the world yesterday in breakout sessions and right here from this main stage, giving ideas about how to meet that challenge. Jim Mackey was under no illusion when he spoke to you yesterday that the waters ahead are very choppy indeed. And then, of course, earlier that day, we also heard from the Secretary of State, Jeremy Hunt, who said, "My hand is the safest on the tiller. Trust me to get you through these waters." So there's been a lot of talk about how you get there to 2020, and a lot of talk about the way in which this is going to be a bottom-up change, Or is it a top-down change? I know people have been coming to me saying they're a little bit confused about actually just how is this going to work? Is this structure that I keep describing, this samosa structure, let's get ethnic about it, but you know, sort of you've got a Simon Stevens on top of Jim Mackey, these 44 heads and all of you. Is that how it's going to work? There are a lot of questions. A man who has many of those answers is going to speak to you now. Please put your hands together and give a very warm welcome to the Chief Executive of NHS England, Mr. Simon Stevens.
Morning, Anita, and thanks everybody for dragging yourselves out of bed. I hope you had a good evening. I didn't, unfortunately, have a chance to hear Jeremy yesterday, but I did hear Jim, and I thought Jim was bang on the money. So really, all I'm going to do is elaborate on some of the themes that both he and I feel so strongly about, and that I think hopefully also pick up some of the feedback that I got as to some of the points that have not yet properly been addressed through the Confed conference this year. But I want to start where Jim started, and I understand Jeremy as well, by just acknowledging that it has been an incredibly demanding year since we last met in Liverpool. I know it's tough for frontline staff across the NHS. I know, certainly in my 28 years in and around the NHS, there's never been a more complex time to be a health service leader. So let's just start by acknowledging that, and let me also thank you for the work and the leadership that you have shown in your communities, in your organisations, your parts of health, social care over the course of the last year. Fact is that we hold ourselves to a very high standard, rightly so. And despite all of those pressures, there is no other major industrialised country in the world that, over the course of the last year, can claim to have treated 9 out of 10 of its patients within 4 hours in an A&E department, or provided 9 out of 10 of its citizens with access to needed planned surgery within 18 weeks. If you look at the groundbreaking study published in The Lancet a few weeks ago, the lead author being a guy who actually works for me at NHS England, Maheben Marathapu, Britain and the fact that we have an NHS has protected our citizens from the effects of austerity when it comes to cancer mortality, for example. Across the OECD, during this period of austerity, 260,000 excess deaths from cancer, not a single one of them in this country, thanks to the protective effects of the NHS. One of the biggest public health challenges we face in the world, antimicrobial resistance, killing 50,000 people a year in Europe and the US. Last year, we made one of the world's biggest improvements in the reduction of unneeded antimicrobial prescribing, 7% for GPs. I just use these examples because although, of course, we have a focus on A&E and a focus on elective care, actually there's far more going on across the National Health Service than people pay attention to. And despite all of the pressures, I challenge you to ask any doctor, any nurse, any patient, in fact, would you rather be treated now compared to 5 years ago or 10 years ago? And the fact is that anybody who knows what they're talking about would say that the quality of care on offer to the people in this country for the vast majority of conditions is better now than it has ever been. And that's not just true for the clinical quality of care, it's also due, I think, to the compassion and the sensitivity with which care is offered. My mother gave me this newspaper article a few weeks ago. She's obviously full of insights into how the National Health Service should develop. And this newspaper article said as follows: "Many people, disturbed by incidents which they feel should not happen, are beginning to wonder whether or not our hospital service is lacking in humanity. In one hospital until quite recently, the relatives of a deceased patient were coldly informed of his death by a printed form, an example of administrative remoteness that is not uncommon. The hospital, which plays such an important role in the community, appears in many ways to be cut off from it. This form of institutional autonomy is inevitable unless it is appreciated and guarded against." And the article described humanity in hospitals, and it was written in 1960. And she sent it to my dad, who was at that point working as a hospital porter in Birmingham. So the notion that history began with Mid Staffordshire Hospital, I'm afraid, is not true. Progress has and is being made, and none of that is to deny or undermine the very real pressures that are being experienced across the front line of the National Health Service. And as I was talking yesterday afternoon to the group of graduate management trainees who were here at the Confed conference, it put me back 28 years when I started on the management training scheme in Consett in County Durham. And the discussion that we were having was, how has the nature of leadership, how have the challenges facing the health service changed over that period of time? And it clearly is true that during the 2000s, certainly, the big challenge confronting us was how to use a substantial wodge of extra cash and turn that into improved access, shorter waiting times across the NHS. And you know what? We did that incredibly successfully. As a result, waits, as we all know, fell from 18 months to 18 weeks. Public satisfaction with the NHS doubled. And to some extent, one of the biggest public frustrations with the NHS was taken off the table. However, as we also know, the circumstances facing us now are different. The challenges are different, the financial circumstances are different, and therefore our response needs to be different. And in some ways, as I was talking to these graduate trainees, we were talking about the impact of the 2012 reforms. It struck me that in some ways they were the high watermark of the solutions to the previous set of challenges that we're facing. And so when it comes to institutional autonomy or tariff-based componentware or a regulatory approach to improvement, actually that to some extent now is having to be superseded by an evolving set of arrangements. And part of what I've been trying to do with colleagues in the 2 years since I came back to take on this role is both establish the shared consensus about how health needs to evolve in this country, which we've done with the forward view, create more alignment nationally between the various parts of the system, and the creation that we put together last year, NHS Improvement, I think is going to be an important building block with that. And obviously then making our public argument for a stronger funding settlement as we can get for the National Health Service. And since we were together in Liverpool, obviously we've had the spending review outcome. So I saw in the kind of Twitter streams various kind of critiques of the conversation here yesterday and the day before, suggesting that nobody had really talked about the money or the lack thereof. So let me just kind of lay out what I see as a few kind of home truths on that front. First up, let's not rewrite history. In the forward view, we actually said that the National Health Service would need between £8 and £21 billion by 2020 in order to sustain and improve. And to be at the lower end of that range, we would need to see continuing access to social care relative to need. We would need to see enhanced effort on prevention and public health. And we would need to see transformation support in the way of capital and revenue. And we have memorialised all of that. It's the recap briefing that's available on the NHS England website, so everybody can see what we actually said when we set out our stall back in 2014 on the forward view. We made our case in the spending review. We have a U-shaped funding settlement, which, against a very difficult fiscal backdrop, I think can be regarded as good as would be obtainable under those circumstances. And so overall NHS funding, as you know, will grow from about £100 billion to £119 billion over this period. But there are three important consequences of the SR which are really relevant for the conversations we're having now through the SDP process and things we've got to get right this coming year. First is that capital is incredibly tight. So as we think about our plans, our redesigns in the 44 geographies across the country, solutions that are heavy on capital expenditure, right now it's hard to see how they are going to be financeable. The second impact is that a lot of the improvement we want to see in new funding programmes, be it mental health services, cancer, other, the extra purchasing power for that, regrettably in some ways, but just as a matter of fact, let's be honest about it, a lot of that extra purchasing power is back-loaded, back-ended towards the sort of 2019-2020 period. And the third consequence of this U-shaped funding settlement is that this year now really matters. We've got to use 16-17 as the reset moment to get our finances, our performance back in a place where we can then pivot off to the rest of what this 5-year settlement looks like. So, times are clearly tight and tough. I do not believe that it would be prudent for us to assume any additional NHS funding over the next several years, not least because I think there is a strong argument that were extra funding to be available, frankly, we should be arguing that it should be going to social care. That's one of the arguments that I've been making publicly, and I think social care has a very strong case for that. And of course, who knows what the circumstances are that we will face as of June 24th. So, in practical terms, what are the tasks in front of us as leaders in the NHS over the next year? I endorse what Jim said, and I would essentially put them into 3 categories. First of all, there are a set of practical things we've got to do this year to stabilise our finance and our operational performance. Jim laid those out. I'm not going to repeat all aspects of that, but let's just be clear. Finances do matter. The control totals that individual organisations will be accountable for do matter. And this is for a purpose. The purpose is that we have had to strip out 1%, call it £650 million of spending from funding that would have been available from CCGs for mental health services, community health services, primary care, other things to hold as a contingency reserve going into this year, given what happened last year. We want to be able to release that funding and spend it on mental health services and community services, so our delivery on these control totals through the year will have a direct impact on our ability to free up that incremental spending for the priorities that we know we've got to resource. People have talked about Carter no end. There are significant opportunities both inside and beyond individual institutions. We now don't have the luxury of time on that. And by the way, the same applies to CCGs and the right care agenda. That is now absolutely mission critical for the sustainability of what the next 3 or 4 years look like. This is not any longer a special project or a hobby. Secondly, we've got to get our sleeves rolled up and get delivering on some of the key national priorities and strategies that we've laid out. NHS England, we're now out of the strategy business. We've got the forward view, we've got a cancer task force report, we've got a mental health task force report, maternity, the urgent emergency care review. We're not doing any more reviews, not doing any more strategies. We're now purely sleeves rolled up, getting into the implementation alongside you of what those look like. And to help us do that, over the last several months, I've appointed 5 of the most superb operational managers in the National Health Service. They all happen to be women chief executives from different parts of the NHS. Pauline Phillip to lead our implementation on urgent emergency care review. Callie Palmer, chief exec of the Royal Marsden for cancer. Claire Murdoch for mental health. Sarah Jane Marsh for maternity services. Sam Jones, you know, on Vanguards. Those 5 frontline leaders connecting the national implementation agenda with the local work that's got to be delivered in every part of the country. And we can talk specifically about what that will mean, but on cancer services, for example, anybody who's not got their sleeves rolled up looking at what's happening to endoscopy bottlenecks, that part of the care pathway, you're not going to do your Cancer 62, that matters, but there are a broader set of changes that Callie Palmer will be talking to these reformed cancer alliances about. Claire will be doing the same on mental health. On mental health, the practical things for this year are the work to reduce out-of-area treatments and to connect secondary and tertiary mental health services that Stephen Fern will be leading. The 2 new mental health waiting times goals that we have around IAPT and early intervention psychosis services, and expanding child and adolescent mental health services, one of the parts of the mental health system that is most creaky. And then alongside that, we need open book transparency from CCGs so that their mental health trusts can see where mental health investment is or is not going, and we can have an honest conversation about that. For urgent emergency care review, we're going to be, in the next several weeks, setting out 5 key things that in 16-17 we need every part of the NHS to do. Part of it will be about souping up the 111 on GP out of hours front end, more clinical intensity of engagement there, various other internal process issues, and a big focus on delayed transfers of care and the interactions with social care. On learning disabilities, we're making quite substantial progress on reducing your chances of being institutionalised if you live in the top half of the country, with a clear programme to close the last of the long-stay learning disability hospitals, Calderstones. And on GP services, even those of you who don't directly work on primary care, you are on the receiving end of the benefits of a well-functioning primary care system and the consequences of not having that. So we've got a huge effort on to help respond to the very genuine pressures that have been building in general practice, receiving far less attention than the pressures in other parts of the system. And so on workforce, on workload, on work redesign, if we don't get this right over the next 18 months, then, as a headline in the BMJ put it recently, if general practice fails, the whole of the NHS fails. We have a shared interest in really ramping up our implementation effort on primary care. So, of the three things for this year, stabilising finances and operational performance in the way that Jim described. Secondly, practical actions to implement the first phase of these national improvement strategies, similar in some ways to what we did with the national service frameworks in the early 2000s. And then thirdly, actually landing these sustainability and transformation plans, these SDP processes, in every part of the country. Now, let's just be frank about it. To some extent, these are workarounds on a set of institutional arrangements, a set of governance structures, a set of incentives that are pulling people apart when actually we need to hang together. And the reason I'm optimistic about this, without being naive, is that I think we've seen in some parts of the country some pretty rapid change over a relatively short period of time. A year ago, I talked about success regimes, and we kicked off the first three of those, one of which was in Devon. And it is, without a doubt, I think, a dramatic change in the shared sense of leadership and purpose that has occurred in the space of just a year. When I sat down with Bob Alexander and the chairs of 5 of the organisations in Devon some months ago, and had a fairly straight conversation about the way to resolve their differences was not to be issuing press releases, which is how they were essentially doing their contractual negotiations, and that were that to continue to be the mode of operating, then we probably would not all be in the same room together in quite that way. Subsequently, the fact is that they have completely changed the dynamic. Angela Pedder, Chief Executive for All Devon and Exeter, taken over leadership of that, and I see those kinds of changes underway in many parts of the country. But as we try and land these SDPs, I would kind of think about three kind of sort of headlines, if you like. First is horses for courses. How the health and care system evolves in different parts of the country will look different. That's fine. One of my kind of guiding principles here is that it doesn't all have to look the same everywhere. The solution for Lincolnshire is not going to be the same as the solution for South East London. That's okay, but it does need to be a solution. So STPs are not a bidding process. Again, as Jim said yesterday, they're a problem-solving process. They are a way of having a focused, honest, trusted conversation about some of the elephants in the room, some of the big-ticket items, the difficult choices that need to be resolved. And how they are resolved will look different in different parts of the country. So it is horses for courses. But I think the second phrase that comes to my mind is, if not now, when? In so many of these conversations, and I've had the benefit of sitting down with 24 out of the 44 STP leadership groups, in so many of these processes, it's not that people don't know what has to be resolved. It's often that people have known about it for years, just the time has never been quite right. Well, it seems to me that at a point when our backs are against the wall, where we are at this point in the political cycle, where it's pretty obvious that the money's not going to work if we carry on as we are, then if not now, when? And so, as we have a chance to sit down again in July, I'm personally with Jim going to do all 44 of these. I've blocked out a large chunk of July just to make sure we're having these very specific and important conversations. If not now, when? We've actually got to face up to some of the changes that we can see are required. So horses to courses, if not now, when? And then the last of the thoughts, it seems to me, is how big a team are we playing on? And I've talked about the Devon success regime. I don't in any way do anything other than commend really effective organisational leadership. And some of our most successful leaders, you think about people like Len Fenwick, who, as you know, has just celebrated 50 years as an NHS manager. Newcastle Hospitals just getting their outstanding CQC designation. And I was chatting to Len earlier in the week, and I think he's written a piece in the HSJ this week as well. I mean, Len probably doesn't want to do a population-oriented ACO construct of some sort, and you know what? That's fine. But if David Sloman at the Royal Free and colleagues think that for their part of London, or Pauline Phillip for Luton and Bedford and Milton Keynes, then we should be supporting and backing that. But either way, this should not be the consequence of failed arm wrestles. This should be the consequence of thinking more broadly than individual institutions. It's both and not either or. So, in a nutshell for this year, yes, I'm afraid there will be a reset on the money, and it's my job, honestly, to tell you that that I think is something that the politicians will also come to more explicitly in July, so we might as well recognise that and be getting on with it, rather than waiting for it to come and bite us later in the year. We know that there are a set of practical things to continue to show progress on mental health and cancer and learning disabilities and our other national priorities, and we've got to make this SDP process work. It is going to be bloody tough. Let's just be frank about that too. But that is what the nature of the leadership challenge is in front of all of us right now. And as we do that, it's very important that we think about some of the broader context within which we're operating. Our staff, our frontline workforce, obviously this has been a difficult year. The junior doctors' industrial dispute, pressures on staffing, the agency cost cap, the implications for that, the attempt to move back from the de facto casualisation of parts of our workforce through locums and the difficulty of converting that into permanent workforce and so on. But what strikes me, as I do spending a lot of time out and about around different parts of the NHS, is that quite a bit of this is actually in the gift of individual organisations and employers, and you can sense that difference when you walk in the door. One of the things that it will make a huge difference is if all of our staff feel they are getting a fair crack of the whip from the NHS. So any of you who have not yet looked at the workforce race equality results for your organisation, I would really urge that you do so. And what we see across the NHS as a whole, of course, is a huge difference in the experience between black and white staff across every part of the NHS, but with some organisations having really acknowledged and acted on that in a dramatic way. The NHS, unfortunately, is not the world's best employer when it comes to the health and well-being of our own staff. We've put £450 million of incentives through the Sequin scheme available for staff health programmes over the course of this coming year. I would urge you to mainstream that as a central part of the dialogue you're having with staff across the NHS. As you do that, you can think about how you frame that message sensitively. I perhaps had a slight misfire. This is the way the Sun newspaper reported my efforts on this one. Weights up doc, fat medics ordered to slim by NHS chief. I'm not suggesting that is the headline in your staff newsletter, but the fact is there is opportunity there. And as we do that, let's also not just let this be a kind of grim conversation about kind of grinding out the money under difficult circumstances. The fact is the NHS also is an incredibly innovative organisation, has been since the year dot. If you want to know where IVF, joint replacements, vaccinations, organ transplants got off as gifts to the world, it was the NHS. And I think we are leaving money on the table and we're leaving opportunity unaddressed in the way in which we're using some of the innovations that our clinicians can see would make a difference, but we're not getting them out and about. So one of the things that we're announcing today is that from April next year, We will add a piece to the national tariff system specifically for new medtech innovations that have been shown to be cost-saving or help patients with supported self-management. Look, the tariff is not the be-all and end-all. This is not a solution to all that needs to get done, but it is a way of trying to fast-track beneficial innovation into frontline clinical practice, to take out the hassle of having to try and negotiate these things on a trust-by-trust or practice-by-practice basis. And the reality is that actually, if you sort of begin to look at what some of these prospects are, it can get quite energizing and quite exciting. I'll give you one very simple example. Here's my iPhone. Here is an ECG machine now for under 100 quid. Probably going to put this on the national tariff for next year. 2 million people in this country got atrial fibrillation. About 20% of strokes caused by atrial fibrillation, a lot of it undiagnosed. We've got different parts of the NHS now beginning to use this technology. We should just make that a national reimbursable part of what we offer. Likewise for COPD. We've got health apps being used for the million patients with COPD, 90% of whom struggle to administer. So when we talk about the 22 billion savings and we talk about demand management and all the rest of it, it's things like atrial fibrillation, it's things like COPD. It's things like the fact that in intensive care units, 20,000 patients a year get ventilator-assisted pneumonia with a 30% mortality rate. It turns out there's a small inflatable tube that you can put into patients' throats, and as a consequence, that practically eliminates the risk of pneumonia-related death. We're using it in Birmingham, we're not using it across the rest of the NHS, saving about £700 a patient. Again, let's get these kinds of innovations diffused much more quickly, much more widely, and I think if we do that, we will see not only alignment with clinicians who generally are up for and excited by and can see the benefits of this, we will see the benefit for patients, and it is a much more inspiring and encouraging way to go about modernising our care delivery than simply the grind of cost takeout and reduction through conventional means. So, in a nutshell, yes, it's been a tough year. Yes, it's going to be tough sledding over the next 3, 4, 5 years. Certainly, I and colleagues will be making the case for the National Health Service and its resourcing forcibly and publicly, but we should not kid ourselves that that by itself is going to buy us comfort in the status quo. So I think in our heart of hearts, we know what needs to get done. Our job nationally as the national bodies is to seek to support you in doing that. Half term, I took my kids away for a week down to Cornwall. My dad was just turning 80, and my brother and sister went out on one of these bloody mackerel fishing trips, which kind of always makes me feel slightly ill. But anyway, as we were pulling out of the harbour, the skipper of this mackerel fishing ship, little boat, said, "I'm here to offer you every possible assistance except for actual help." And it struck me that that might be the sensation that some of you sometimes have around the National Health Service. Jim and I are committed to changing that and doing better than the skipper of that Cornish mackerel fishing boat. Thanks so much.
Thank you very much indeed. It's been interesting that everybody has sort of started off with that salutary thing that this is tough. We've got this U-shaped funding. We know that a lot of that front-loaded money is first of all going to go to paying down the deficit. I need to ask you, if 5-year forward doesn't work, if these 44 heads STPs don't manage what you have set them, then what happens?
Well, the 44 are in sort of different degrees of readiness, I would say, and you'd expect that. So I don't think it's going to be a kind of single process of saying, yes, we're signing off all 44 kind of the end of July. There'll be a first tranche that look very strong. They will have our backing. We want a shared understanding of what the kind of difficult aspects of those are, and we'll get to those in end of September, in end of July or September. There'll be another tranche that probably will require some more work, and there are some that are deep-seated and difficult, and I don't know at this point what the answers will look like. So I guess what I'm saying, I don't think there will be, as it were, a single yes-no answer to kind of has in total this got a tick in the box or not for what the health service needs to do. It's going to be a mixed picture across the country. What we're trying to do is raise the chances that we get it right in as many places as we can.
There's been a lot of talk about bottom-up, top-down, sideways, lateral, diagonal, you know, all sorts of things. I've noticed, just as a journalist, that there was a switch where 5 Year Forward suddenly became the Simon Stevens plan, and I have heard talk or questions of where do you fit in this? Are you all-powerful? Is it, as was suggested...
No is the answer to that question.
Is it the illusion of power, was suggested by a colleague, I think, in the HSJ?
I have no illusions.
But where do you fit? How does it work?
Well, I mean, I think we have my responsibilities are probably very similar to the responsibilities that lots of people have in this room. In this sense, I have two responsibilities. I have responsibilities for the organisation of which I'm chief executive. So I have a stewardship responsibility for £105 billion of public funding in the National Health Service, and responsibility for what the commissioning system does. And we want to, frankly, use the commissioning system to drive change in some new ways over the course of the next 12, 18 months. We're going to be getting a lot more engaged and assertive on some of the medicines and therapies negotiations and prices and value deals. We're going to be driving change in learning disability services quite hard through the commissioning system. We're going to be, as we were talking about, trying to use funding incentives to stimulate adoption of innovation more effectively. So that's my first responsibility. And a lot of people here, as chief execs of organisations, have responsibilities to their organisations. My second responsibility is as a system leader, a shared stewardship responsibility, and that both goes with colleagues in the National Health Service, but it also, I believe, I have a responsibility for the broader public conversation that's happening about the National Health Service, and on occasions taking advocacy positions on matters such as prevention and public health and childhood obesity, or the impact of Brexit and various other controversial topics.
I suppose, I mean, I keep coming back to this imagery of a ship on stormy waters. Okay, we have, if anything has become clear over these last 3 days, is just how choppy those waters are. And people want to know who the captain is of the ship. Now, you are increasingly talking to Treasury about matters which affect all of these people and how they're going to conduct their business. I suggested to Jeremy Hunt that actually he might have been slightly bypassed by this relationship. That is Treasury calling the shots? Is it now about money? Health policy is going to be dictated very much by number 11.
Well, first of all, we're not a ship. We're a navy. We're a flotilla. We're not an aircraft carrier. I think that's the right kind of nautical metaphor, if we're looking for one. But it certainly is going to be about a reset on money and the performance that goes with that in 16-17. That's what I mean, you know, the politicians are kind of, you know, there's Purdah and all the rest of it, but I'm sending as clear a bat signal as I can that this is kind of, this is clearly going to be kind of headed all our ways sooner rather than later. And so the earlier in the financial year that we kind of adjust our plans to deal with our run rates so that we don't end up out of whack and then doing kind of panic measures come the autumn, the better for everybody.
Okay, we're going to take questions from the audience. Please put your hands up very clearly and wait till a man with a bat. And if you can make sure the person who has the question has the microphone, just while you're getting yourself sorted out. We heard the Secretary of State make, I thought, quite an impassioned stake on his staking his claim to his job when I suggested to them that actually he may be in quite a precarious situation. Is he still the man for you?
I think we have quite an aligned sense of what needs to change about the National Health Service, actually. There have been points, look, like most of us who've been around the health service for a long period of time, there are points when there are kind of real tensions, there are points when there's kind of alignment on the broad direction of travel, even if the emphasis on different parts of the tactical mix might differ. But look, the fact is that the choice of who is Secretary of State for Health is a matter for the Prime Minister. We live in a democracy, and in a democracy, the elected government decides.
Yeah, I know, but you've got the ear of some very important people, I suppose. Okay. Let us keep sucking your tummies.
Is this your Newsnight audition or something?
No. Do you know, I've been there and I've done that. Been there, done that. This is much, much more fun. Let's go to number 4 at the back. Yeah.
Hello, thank you. This is Dr. Singh. I'm a GP in Birmingham and chair of Modality Partnership. It's a question about boundaries and STPs and the state of readiness of STPs. Our natural population that we're planning for an ACO sits between two local authorities, Birmingham and Sandwell. Our host CCG, Sandwell and City CCG, also spans both Birmingham and the Black Country. Now, my concern and some of my fellow colleagues' concerns are we have two STPs. We have BSOL and the Black Country STP. Now, I don't know which one is going to be in a state of readiness first. Are they both going to be at the same time? Are we going to have our ACO plans, and we're really into sort of third gear at the moment and really ready to probably hold the budget, are we going to be carved up into two? Is our Sandwell and City CCG going to have to be carved up into two because there are two STPs?
Thank you very much for your question.
No, I don't think so. I mean, in most parts of the country, the STP geographies, which, are not fixed in stone, they're there for a particular job in hand to be done right now. They're not kind of what the world needs to look like in perpetuity. But in most parts of the country, those were determined locally, and actually the decisions as to how many and where to put them around the West Midlands were not ones that were sort of imposed from elsewhere. So there's a hypothesis, a reason for why those were chosen as a way of structuring the conversation across the West Midlands. But obviously what's happening, as you know better than me very well, is that because of what you're doing for Modality, because of what the GPs next door are doing in our healthier partnerships, if that's what they're still called. I know you guys keep changing your names about every 5 minutes. But the primary care kind of groupings are, as a result, able to take on a lot of the responsibilities that previously would have been chunked into the CCG layer, and that's part of the reason why the CCGs across town are looking at whether they should be doing more sharing or combining. And I thought, although, as you all know, I'm sort of generally speaking quite averse to the idea of just constantly tinkering with administrative boundaries and reorganisations, I thought, as is so often the case, Alistair McClellan wrote a very kind of insightful editorial this week in the HSJ on some of these topics. So I think, we will be guided by a combination of what you and Julie Moore and Stephen Dorrell and others who are leading the SDP processes in your area say. That's part of the conversation I expect to have with you in July.
Let's take a question from number 5. If you could keep the questions brief, that would be marvellous. Thank you.
Hello, Simon. It's Tim Cotton from West Hampshire. So we're in a bit of a conundrum here. We got to get the sustainability right, so it's a platform for transformation, yet without transformation, sustainability is going to be unattainable. I heard you say that the control totals are important, the money's important, but there's something about the acute trusts sorting that out, then whatever's left over is there for transformation, for community and for primary. What's your messaging around that? How do we do that?
Yeah, so no, that's not quite what I was saying, but let me just thank you for giving me the chance to be clear about this. For 16-17, the year we're in, obviously we've now got in effect a set of commissioning allocations, fund flows and so on that have been agreed. The bit that is still to be finalised in a small number of trusts by Jim and I is what their control totals will be. My point is that, as you know, in your CCG and others, we've got a holdback at the start of the year in order to give ourselves some cover for pressures both on the commissioning side and elsewhere in the system. If we get to midway through the year and we're actually delivering on the aggregate position that we will have agreed both on the commissioner and the provider side, then that will free up. That will mean that we can begin to disperse, CCGs can begin to spend in year some of that money that is held as contingency. And I would like us to be able to do that. And the reason I would like us to do that is because it's pretty clear, I think, that on mental health and on primary care, and to some extent community services as well, the consequence of not is that we're just kind of on this treadmill effect with demand flowing into hospitals and or big areas where we would get huge health gain if we could put some purchasing power behind it. So I guess the point I'm simply trying to make is that living within our means during the course of this year is not just something we have to do because in a democracy Parliament decides how much the NHS will spend. We don't just get to decide our own deficits. but more because it actually will free us up some of that purchasing power to do the important things we know we want to do.
I'm going to try and squeeze two more questions in. Let's go to number 3 first of all, and then number 2.
Good morning. Fran Beck from Telford and Wrekin and Shropshire CCGs. I'm the Director of Strategy. An interesting statistic from the conference. Yesterday, there were 1,100 delegates here, plus all the exhibitors. Of those, 7 individuals attended the free and excellent yoga sessions. Now, I suspect...
And I have to sadly report I was not one of them. Right.
Well, yes.
Yeah.
Now, I suspect if you looked at the number of people that availed themselves of the various free Prosecco sessions that were going on around the place, and you alluded at the very start to people having had a good night last night. And I'm just intrigued to pick up on your comments about improving the health of the NHS, given that we are the 4th or 5th biggest employer in the world.
Okay,
Not
thank
quite
you.
sure we're
Good
there
question.
yet.
Yeah.
Well, obviously when I said I hope you had a good night last night, I meant that I hope people had good yoga sessions last night.
Of course you did.
Manchester is famous for it.
Okay, question number 2.
Thank you. Cathy Winfield from Berkshire West. Just wanted to pick up on your statement at the beginning that the funding offer was contingent on continuing access to social care, and the real pressure we've seen, particularly this year. I've got 3 small authorities that I work with. One of them has had a 40% cut in adult social care. Our Fit to Go list has trebled in the first few weeks of the year, and for the first year in a long time, our 4-hour target looks at risk in Q1. So a real issue for us about, despite our best efforts, despite strong partnership working, social care remains a huge issue and the thing that could tip us.
Yes, so I think I'd say 3 things, Cathy. First of all, I agree. There is, the polite way I've described it is that the social care funding piece is unfinished business. That I think it's obvious that there is going to be a widening gap between need and funding over the course of the next 3 years. There's uncertainty about what the back end of the period looks like, given the way business rates are being recycled into the local authority funding settlement. What I would say about that is that I think the kind of national awareness of that has kind of moved from denial to acknowledgement, and now we've got to move from acknowledgement to solution, and that is something that certainly I and colleagues are sort of advocating and pushing and working on, both publicly and behind the scenes to some extent. So the overall resourcing question, I think, is absolutely clear. But the second thing I would say is that despite that, there still are some local authorities and parts of the health service that have actually made substantial improvement over the course of the last year. And I don't know if anybody's here from Oxfordshire or Oxford Radcliffe, but I mean, it was the case 18 months ago that there was a real problem, and actually as a result of kind of improved alignment between the local authority and the acute trust in particular, with support from CGI, big improvements there. So improvement is possible even within that funding envelope. And the third thing I would say is that in some parts of the country, part of these SDP conversations, I've been actually very impressed by the quality of the leadership that the local authorities themselves can bring to some of the health services' own issues. And sometimes, there's a problem of kind of, you're so close to it, you don't kind of see it for what it is. And actually, local authority chief execs, leaders, in some places, I felt have brought a great sort of objectivity to the analysis. And I wouldn't be surprised if coming out of the SDP process, we don't decide that in some places the local authorities might take on even more of a leadership role for parts of what have traditionally been NHS functions.
Thank you very much indeed. A really interesting, and you're going to be around anyway if people want to speak afterwards. He'll be in the lotus position a little later on. We're going to have a short, they call it comfort break, but go and do a wee. And then we'll be back here very shortly. There will be the brilliant rock choir outside to entertain you, and we'll see you back here very shortly. Thank you very much indeed.